The next speaker will be none other than Dr. Lata Venkatraman.
Anyway, delivery in PIH, when, where, and how. Do you all agree that we face a lot of dilemmas? Yes. Planned childbirth on the best day in the best way will give the best outcome. But are we able to do it? Okay. Birth of the baby is always in the best interest of the woman. Agreed? Yeah. So we want to really deliver her. Otherwise, we feel very, very tensed. It leads to a lot of obstetric distress. But many times, we won't be able to deliver her because the goal of expectant management is to achieve fetal maturation in utero. So as obstetricians, we are always standing here, prolong the pregnancy for fetal benefit or deliver for maternal benefit. Factors which influence the timing of delivery is the disease severity, maternal and fetal condition, and gestational age. Now, there are some situations where you have to deliver the woman according to all the college guidelines. So indications for delivery at any gestational age is maternal indications, eclampsia, pulmonary edema, cerebrovascular accident, renal failure, progressive liver injury, hemopoietic derangement, persistent fulminant symptoms, term more than 37 weeks where you think there's no point waiting. Fetal placental abruption, severe FGR with Doppler changes, non-reassuring fetal status for any other reason, and intrauterine fetal death. So in all these situations, you would deliver. Agreed? Thank you. So above 37 weeks, as I said, we should be delivering these women according to all these colleges. But mild to moderate, you might take a bit more time if the cervix is not very favorable, and it should be offered. Actually, the delivery should be offered between 37 and 40 weeks. Induction at this gestation was not shown to increase delivery by cesarean section and reduce major maternal morbidity. It is a famous study, Habitat study, which said this. But in the meanwhile, don't forget about the surveillance, maternal and fetal surveillance if you are waiting on her. Delivery, in the absence of progression to severe disease, women with gestational hypertension or preeclampsia can continue pregnancy until 37 weeks gestation. This is for women, this is between 34 to 37 weeks. Okay? These are late preterms that you want to avoid because late preterms and early terms are associated with their own neonatal morbidities and mortality. So can we prolong the pregnancy? Again, yes, says Habitat study. And in the absence of progression to severe disease, they can continue pregnancy until 37 weeks gestation. So a strategy of expectant care at these late preterm gestation ages is advantageous to the fetus. The greatest dilemma is here. In our country, probably we should say 25 weeks to 34 weeks. The optimal timing of birth for women with preeclampsia depends on evolving manifestation of preeclampsia in one or more organ systems for the woman and the baby. So the care, the timing of delivery has to be individualized. But what are the facts? 40% of women are eligible for expectant care. They don't get into dire problems. So is it not right that we give time for these women? The median time of pregnancy prolongation is 7 days with a range of 2 to 35 days when you are doing an expectant management in this group of 24 to 34 weeks. And a day more in utero reduces an ICU stay by 3 days. A week more in utero matures the baby by another 10% and reduces all the complications. So, do we want to be cautious and give the baby the best chance? I know we are all sitting on a powdered drum, okay? Especially with the mother, we are in a situation where the balance can be tilted anytime. It is very important to monitor this lady to see whether she is developing any severity of hypertension or any complication. So maternal evaluation includes monitoring of BP intake and urine output chart, cerebral status, and presence of persistent severe epigastric pain, that is symptoms of fulminance. Laboratory evaluation, probably twice a week or more often, depending on the situation. Fetal evaluation includes ultrasound assessment for fetal growth, AV, that is amniotic fluid volume, and Dopplers, and also CTGs as and when required. So when do we deliver in this situation? When you are waiting, if she develops resistant severe hypertension, eclampsia or fulminant preeclampsia, and presence of multi-organ dysfunction, severe IUGR with abnormal Dopplers, suspected placental abruption, and fetal demise. These should make you deliver this woman when you have been sitting on her. Always document a care plan when you have been waiting. Nature of fetal monitoring, indications for delivery, and when should corticosteroids be given ideally, and discussions should take place between neonatologists and obstetric anesthetic staff. Once the decision is made for delivery, magnesium sulfate should be administered at least 4 hours for neonatal benefits or to protect the mother in labor or during section, and for at least 24 hours postpartum. So 24 to 34 weeks reduces neonatal morbidity and maternal risk. Maternal risk, whether it increases, we are not very sure, but the treatment has to be, the timing of delivery has to be individualized. Timing of delivery would have been better if we could predict the complications. Do we have any tools? Full Pierce and probably the S-FLIT. S-FLIT is a new block on the kid, new thing, but it can be used. It is becoming available. One word about HELP. HELP, in spite of the lady developing HELP, you can complete the steroid course with careful monitoring of both the mother and the fetus and prepare her for delivery. It's not a must that she needs to be delivered by cesarean section. You can induce them. Less than 24 weeks, what do we do? Okay, expectant management of preeclampsia. In spite of that, you can have 80% perinatal mortality. So there is no point waiting. Deliver if unlikely to achieve viability within 1 or 2 weeks. That's why if it is less than 24 or 25 weeks in our country, I think you should be delivering them. And make the parents accept non-viability of the fetus or the baby. Where do we deliver? If it is just gestational hypertension or uncomplicated preeclampsia, probably level 1. Severe preeclampsia, level 2, where you have facilities for comprehensive emergency obstetric and neonatal care. Tertiary care facility for all severe complications of hypertensive disorders of pregnancy, that's pulmonary edema, renal involvement, coagulopathy, HELP and its complications. HELP you can still manage in level 2 if you are capable, and persistent coma after convulsion. How to deliver? Up to 36 weeks, they should receive steroids. 1 shot of steroids, that is 2 doses of steroid, 1 course of steroid should be enough. Magnesium sulfate neuroprotection, I have already mentioned. It should be 1-to-1 care if you are making the lady labor. BP recordings every hour, and assessed for symptoms suggestive of severe disease throughout labor, and continuous monitoring of FHR and uterine activity, because presence of uterine tachysystole or recurrent FHR decelerations may be the first sign of placental abruption in these cases. Mode of delivery, so many factors have to be taken into consideration: gestational age, fetal presentation, presence or absence of severe FGR with Doppler changes, FHR monitoring facilities, Bishop score. So mode of delivery should depend on the severity of the disease and the likelihood of a successful induction. How do we deliver? Most of the time, mode of delivery is likely to be cesarean in less than 34 weeks. More than 34 weeks, induction if mother is stable, fetus not compromised. PIH without fetal compromise, the mode of delivery should be based on the clinical circumstances and usual obstetric indications. Gestational hypertension or preeclampsia is not an automatic indication for cesarean delivery. Induction of labor, yes, you can induce these women, but it takes more time and is less successful than in women with normotensive pregnancies. That's what the literature says. But one should be patient enough to give them a vaginal delivery. An unfavorable cervix does not preclude successful induction, and neither IUGR nor oligoamnios are contraindications for induction of labor. You should have proper monitoring facilities, both maternal and fetal. Analgesia, epidural is appropriate for women with preeclampsia during labor. And regarding the use of epidural analgesia in women with preeclampsia with severe features, evidence suggests that epidural analgesia is still safe, because our anesthetists should not be refusing to give analgesia or anesthesia, neuropraxial anesthesia to these, anesthesia to these women. Anesthesia during section, spinal is preferred method. Hematoma, risk of hematoma is associated with neuroaxial anesthesia with platelet counts of only less than 75,000. More than 75,000, risk of hematoma is very low. GA, please caution. It should be a senior anesthetist, especially if it is a GA. Hypertensive response to intubation can be a cause of direct maternal mortality on the table. Please be aware. Avoid GA. But if they had coagulopathy, pulmonary edema, etc., I think GA should still be the choice with a senior anesthetist holding them thing. Okay, labor, mild to moderate hypertension, no need to cut short second stage. We don't have to be doing instrumental deliveries left, right, and center. Beware of PPH, especially with thrombocytopenia. Avoid ergometrin. Oxytocin, use it as an infusion, no bolus. Postpartum care. Increased risk for pulmonary edema. These women should be watched in HDU. Okay, if you are delivering them for the sake of maternal safety in preeclampsia, please keep them in HDU. Use Muse chart. We had demonstrated Muse chart yesterday, and it's very much available on the net. So increased risk for pulmonary edema and exacerbation of severe hypertension postpartum is well known. Careful evaluation of the volume of fluids, oral intake, blood products, and urine output is very important. Don't keep rushing fluids. Restrict the fluid to 80 ml per hour, even during labor, 80 to 100 ml. Don't keep using furosemide if she doesn't produce urine. Magnesium sulfate, Caesar prophylaxis for 24 hours after delivery or after the last fit. Well, women might present with recurrent preeclampsia up to 4 weeks postpartum. Please continue with antihypertensives. If they are discharged on antihypertensives, please review them in a week's time to see whether we need to readjust the dose, whether they need to continue, etc., etc. And many women can have a brief period of oliguria following delivery. Please don't panic. That's where you withhold Lasix. Withhold Lasix. It can really perpetuate the preeclampsia, that is the hypovolemia in the intravascular compartment. So conclusions, just half a more minute. When women, 1 minute. 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 1 When should we deliver? It depends on disease severity, fetal condition, and gestational age. Okay? Dilemma in decision making is common, especially between 25 to 34 weeks. Do you agree with me? Yeah, that's the real gray zone. Expectant management should benefit the fetus without greatly compromising maternal health. But monitoring is very, very, very important. Maternal and fetal surveillance is very important if expectant management. Prediction of mothers at increased risk of deterioration is difficult at present. I think we should be using full pairs or SFILT if it's coming into the market. Full pairs, the app is available on the net. Where do we deliver? Depends on the facilities in your setup, level 1, 2, 3. You have to assess the patient and decide for yourself. Please get attachment to a tertiary referral center. If you had problems in smaller places, you should be able to take the woman, transfer the woman safely to tertiary care. How? Mode of delivery depends on presence or absence of fetal compromise, gestational age, and other obstetric problems if they had. Gestational hypertension or preeclampsia is not a contraindication for vaginal delivery. Appropriate fetal-maternal monitoring is a must in labor. You should have all facilities. And also NICU care, multidisciplinary team involvement is very important, obstetric anesthetists, neonatologists, and yourself. GA can be associated with higher morbidity and even mortality. Antihypertensives to be continued postpartum if you want to prevent eclampsia and cerebral complications. So it is, yeah. It is a tightrope walk. As obstetricians, we are all used to all this because we balance our profession, family, yeah, and our patients. What else do we need to balance? So we might not have balanced minds at times. We are excused anyway. Okay? So delivery is always appropriate for the mother, but not always for the fetus in preeclampsia. Thank you very much for your patient hearing.